Hello, welcome to RAAONLINE. I am Dr. Vijay Raghavan. Let's discuss neoplasms of the biliary tree. There are two important malignancies, cholangiocarcinoma and carcinoma of the gallbladder. Let's talk about bile duct tumors. These bile duct tumors cause obstruction to the biliary tree, causing biliary stasis, leading to obstructive jaundice. Stasis leads to cholangitis and hepatocellular dysfunction, leading to progressive malnutrition, renal dysfunction and coagulopathy. Infection, renal dysfunction and coagulopathy are three major issues with patients with obstructive jaundice. What are the causes for cholangiocarcinoma? Chronic inflammation of the duct leads to the cancer. Parasitic organisms lead to DNA changes and tumorigenesis by releasing carcinogens and free radicals. Bacterially induced endogenous carcinogens acting on the bile salt is another possibility. Genetic defects like KRAS shows cholangiocarcinoma. What are the risk factors for cholangiocarcinoma? Family history of congenital fibrosis or cyst. Very important point to remember is Caroli's disease, choledochal cyst and polycystic liver are the risk factors for cholangiocarcinoma. As we said, parasites like Clonarchus sinensis is responsible for cholangiocarcinoma. Typhoid carriers is another risk factor. Gallstones and hepatolithiasis also can produce cholangiocarcinoma, but the risk is more for gallbladder malignancy. Primary sclerosing cholangitis. 1/3 of all these patients have malignancy. This risk is very high in primary sclerosing cholangitis. Ulcerative colitis with or without a sclerosing cholangitis, especially if there is associated cancer colon, which only shows the chronicity of the disease, leads to increased risk of cholangiocarcinoma. Drugs like contraceptive pills, methyl dopa, toxic materials like thorium, radionucleotide causes cholangiocarcinoma. Biliary cirrhosis is another risk factor for cholangiocarcinoma. As we said, patient presents with jaundice, with pruritus, epigastric pain, diarrhea, anorexia and weight loss. Patients are deeply jaundiced with smooth hepatomegaly. Gallbladder will be palpable if the CBD is obstructed, distal to the cystic duct. If there is only one duct involved in cholangiocarcinoma, one lobe of the liver may be enlarged. Coming to investigation, LFTs with signs of obstructive jaundice, which can be progressive or may fluctuate if there is an incomplete obstruction or only one duct is involved. Classically, alkaline phosphatase and GGT are markedly elevated, while AST and LT are mildly elevated. Presence of anemia, elevated WBCs with polynuclear leukocytosis or other features of cholangiocarcinoma. CEA and AFB are normal. Patient often has a pale and fatty feces. The pallor is due to absence of bilirubin in the GI tract and fatty feces because of non-absorption of fat in the absence of bile.